Hello, and welcome to Open Classroom, the Brown School's digital forum for community and conversation, and one of the professional development offerings of the Brown School. My name is Sarah Sims, and I am the manager of continuing education here at the Brown School at Washington University in St. Louis. And I want to thank everybody for joining us for today's program. Before we get started, I have just a couple of housekeeping items. The first is that this is a Zoom webinar, which just means that we can't see or hear you. But as some of you have already started doing, we can still engage with you in the chats. That's open to everyone. So right now, we invite you to say hello, where you're joining in from. And then throughout the program, please feel free to leave any comments or questions in particular for our presenter today, because there will be time at the end for Q&A. The second piece of information is that we are now streaming on YouTube. So I'm putting a link to that in the chat. If any of you have friends or colleagues who were not able to join us today, you can send them that link so they can watch live. And then a recording of the session will also be posted in a couple of days. All right, so that's it for housekeeping. Let's go ahead and get started. Today's program is a part of our curriculum showcase, which is a series within Open Classroom that gives prospective students and others who might be interested in the Brown School a glimpse into what it's like to be in the classroom with one of our esteemed faculty members. So I want to give a special welcome today to anybody who's in the audience who might be a prospective student. We hope that you enjoy the program today and learn a little bit more about the Brown School as well as the topic, which leads me into introducing Dr. Trish Kohl, who is our presenter today. So Dr. Trish Kohl is an associate professor here at the Brown School and the chair of our Children, Youth, and Families concentration. Dr. Kohl's scholarship is focused on strengthening, implementing, and sustaining evidence-based interventions that improve the quality and care for vulnerable families. Through her research, which is informed by years of clinical practice with children and families, she seeks to close the gap between research and community-based practice. Dr. Kohl is affiliated with 2 research centers here at the Brown School, the Center for Mental Health Services Research, and then also the Center for Injury and Violence Prevention. She's also affiliated with the National Institute of Mental Health's Implementation Research Institute. So today she's going to present, her talk is entitled Infant and Early Childhood Mental Health, Supporting Families and Improving Outcomes. So she's going to be discussing risk factors in the family and immediate environment that are highly consequential for children's social and emotional development. And will also introduce us to promising prevention and treatment strategies that aim to support families and their young kids and outcomes. So thank you for being here, Dr. Kohl. Welcome, and please take it away.
Thank you so much, Sarah. Let me share my screen really quick. Here we go. Can you see that?
Yep, yep, that's perfect.
Okay, fantastic. Welcome, everyone. I'm so glad that you are here with us. And Sarah gave you some of my background, but I do want to say my clinical experience, I spent a couple of years in a public mental health center working predominantly in their family preservation unit. I then moved to a private nonprofit that was a therapeutic childcare center, first as a social worker and then as the clinical director. So my practice experience, much of my research experience is really focused on those early years and that foundation that lasts a lifetime. I do want to this is part of the curriculum showcase. So where does this fit? One of the courses I teach is social work practice in early childhood, and this covers these topics and prepares the course actually prepares social workers to intervene with children ages 0 to 4 to 5 years, as well as their families. When we're working with kids this age, we're working with their families. And do want to say that I have condensed about 10 weeks worth of work or in of coursework into this to give an overview of early childhood, infant and early childhood mental health. Okay. We're going to talk about infant mental health, threats to infant mental health, protective factors, as well as interventions. All right. And so the definition 0 to 3 has defined infant mental health as the young child's capacity to experience, regulate, and express emotions, form close and secure relationships, and explore the environment and learn. And so one of the things, we often, as we're talking about mental health, we find ourselves talking about pathology and positive mental health as the absence of pathology. But it is really much more than that. It is this ability to self-regulate, to express their emotions, to engage positively with those in their environment. So I do want to highlight it is more than that. So when we think about intervening at this age, we're both intervening to promote these skills and to promote these competencies and to build out these competencies, as well as to prevent adversity and then to treat the emotional and behavioral disorders. And infant mental health actually develops within the context of the caregiving environment. That includes at the family, at the community level, as well as around cultural expectations. And I'll talk about that some today as well. Infant mental health is very much related to what I'm going to talk about on the next 3 slides. So just recognize that. So of course, our genes influence our brain development. We inherit over 20,000 genes from our parents at birth. But the developing brain is also not only influenced by those genes, but it's influenced by experiences and exposure to the environment. And it's those interactions between the genes and the environment that really affect early childhood mental health. They interact, those early experience, the genes, the early experiences in the environment interact to really shape the architecture of the developing brain, as well as to lay the foundation for early mental health. And I will also say for later mental health as well. So a piece of this, and again, could talk about this for weeks. We're going to, and covering it very, very quickly, this nature versus nurture, gene versus environment interaction is about epigenetics, which is about the ways in which experience can in fact determine gene expression. So those genes, those 22,000, 23,000 genes that we were born with are not actually set in stone. That the expression of those genes is influenced both by positive as well as negative experiences. And so those experiences really, they rearrange the epigenetic markers that govern gene expression, which then changes whether and how genes release the information that they carry. And again, they're influenced by both positive and negative experiences. And the brain is particularly responsive to these influences in early childhood. And I will say the Harvard Center for the developing child has wonderful resources, both in terms of fact sheets, but also videos that really explain these complex interactions very, very well. So I encourage you to explore that resource if this is an area that you're interested in. So the gene environment interaction. So there's more and more science. It's so cool. I will say what we know now and what we're able to learn. But we do know that there is kids are born with a predisposition to health and mental health issues, both in childhood and adulthood. And we have there are ways in which that can be identified. But again, those genes, that predisposition is not set in stone. Environment and experiences do in fact influence their manifestation. And so human development across the lifespan is really shaped by the ongoing interplay among the vulnerability and sources of resilience. And we're going to talk some today about those sources of vulnerability as well as those sources of resilience. And we'll start with vulnerability and talk about toxic stress. And so stress is an inherent part of life. Whether across from infancy through your older adults, it's just a fact of life, and it is that there is a physiological response to stress that can result in brief increases in heart rate, mild elevations in stress hormone levels. So for instance, I do lots of presentations all of the time. I experience that sort of those positive levels of stress, elevation in my heart rate, in my stress hormones when I am presenting. There's even an additional level when presenting on open classroom where I can't see you, and I'm talking to a picture of myself and Sarah. But we're living in the age of Zoom right now, and it increases the risk, so that the reach, which is awesome. But everybody encounters stress experiences. There's also tolerable level of stress that is more serious. And it's a temporary stress response. But the key thing here is these higher levels of stress are also buffered by supportive, positive relationships. However, when we get to the toxic stress, that's prolonged activation of the stress response systems in the absence of those protective and supportive relationships. So that ongoing chronic stress that has a physiological response on children that shapes their development and increases their risk of mental health disorders. And so toxic stress, Shonkoff and his colleagues define toxic stress as the strong, frequent, or prolonged activation of the body's stress response systems to major adverse experiences such as extreme poverty, recurrent physical or emotional abuse, chronic neglect, severe maternal depression, parental substance abuse, childhood sexual abuse, as well as household chaos, in the absence of that buffering protection of adult support. As we relate that to epigenetics, the children that are exposed to this prolonged chronic stress do in fact exhibit modifications in the expression of their of specific genes, and are then particularly at risk for the development of post-traumatic stress disorder, both in childhood and adulthood. And I will say, in early childhood as well, we know that very young children can develop traumatic stress symptoms. They can develop depression and anxiety. One of the things I will say here as we think about, we'll come back to disorders shortly, but in thinking about the diagnosis of disorders in young children, I do want to recommend, and I'm sorry that I don't have it on the slide, but recommend 0 to 3's diagnostic classification system for to 5, the DC-05. It really takes into account the developmental aspects of diagnoses that we do for those youngest kids that we don't see in the DSM. So I do want to put a plug out for 0 to 3's diagnostic classification system. So other types, so I mentioned within that definition, some types of stress, other types of traumatic stress, exposure to violence in the community, violence at schools, complex trauma, so those multiple or prolonged trauma, exposure to multiple traumatic events, exposure to intimate partner violence. My dissertation work, much of my practice was at the intersection of intimate partner violence and child maltreatment. My early research was on that intersection as well. And exposure to intimate partner violence is certainly a form of traumatic stress. We think about maltreatment, but accidents, medical trauma, traumatic grief are also all aspects of traumatic stress that can, in fact, have very adverse effects on children, particularly in the absence of that buffering, supportive, protective adult. So as we think about young kids and their exposure to trauma, it is also really important to assess how the parent is doing, because it matters. And we know actually there's a good body of research following 9/11 that talks about the relationship between the parent's adverse effect to traumatic experiences to that of the child. And it's really difficult for the parent to be that buffering supportive, have that buffering supportive role when they themselves are experiencing traumatic stress. And so both assessing and identifying and responding to traumatic stress, both among the child and the parent, I think is really important.
Trish, are you still with us? It looks like we might be experiencing just a lag. Hi, everyone. I want to apologize for the technical difficulties here. It looks like Dr. Kohl may have experienced some internet issues at her home office where she's zooming in from. I will take a moment to briefly pause here and hope that she's able to rejoin us. As we're doing that, I just want to remind everyone, here she comes back in. I just want to remind everyone that you can post questions in the chat and we can answer those in the end. Dr. Kohl, you're back.
I'm back, and I don't know what, oh no. Okay, I'm back. Okay. I don't know at what point you lost me.
You had just started your new slide. It's the one right after where you had listed the types of traumatic or toxic stress.
Okay.
It was the slide right after that. You had just shared it and we're about to explain.
Okay, perfect.
Yep.
Okay, so did I talk about?
Sorry. Yes, you did.
I talked about this one.
You can go on to
the types of toxic stress. Okay.
And the next slide.
The next slide. Okay. So we have the ACEs study, which it has really looked at those adverse experiences in childhood and how they impact health and mental health in childhood as well as in adulthood. We know that multiple exposures are common, and that it has really highlighted the long-term medical and public health consequences of child maltreatment. Have a screenshot here of the of a information sheet, a fact sheet put out by the CDC. One of the things we know is that 1 in 6 adults experienced 4 or more types of ACEs. At least 5 of the top 10 leading causes of death were associated with ACEs, and that preventing ACEs could reduce the number of adults with depression by as much as 44%. So we know that, coming back to that toxic stress, it can change, that the toxic stress from the ACEs can change brain development and affect how the body responds to stress. And as we think about intervening early, it is really important then to intervene to prevent adverse early childhood experiences, because that will lower the risk for these later mental health and physical health problems. It also improves outcomes across a host of domains that I'm actually not gonna talk about, but are really and we see, I will say, we see more and more this of ACEs being, we're assessing for ACEs in many settings at this point, which is really good. But I am a strong advocate of let's prevent. Let's actually intervene early to, in fact, prevent adverse childhood experiences as well, which then improves or reduces the risk for children to develop emotional and behavioral disorders in early childhood, as well as later childhood and adulthood. So then the other piece to that is, so we talked about the vulnerability, but also then the sources of resilience, the sources of support. And so protective factors are those conditions or characteristics that reduce or eliminate risk and promote healthy development and well-being of children and families. It is very much a strength-based approach. And when we think of interventions, we want interventions that decrease the risk and decrease risk factors and increase protective factors. So the Children's Bureau has identified several protective factors. This includes that parent-child relationship, nurturing and attachment. I'll sort of add that the responsive parenting, meeting the needs of being responsive to the needs of the child, knowledge of parenting and child development, parental resilience, social connections, concrete support, And then the social and emotional competence of children, which is characterized by young kids' ability to develop positive relationships with others, their ability to coordinate and communicate their actions and feelings with others, recognize and regulate emotions and actions in social settings and interactions. And as kids develop from infancy into toddlers and preschoolers, this becomes really, really important. And those early interactions in infancy, the groundwork for later social competence as young children begin to interact with others. Then we also have resilience. And I love how Ann Maston talks about resilience as ordinary magic. It is that positive adaptation in the context of risk or adversity, that in spite of adversity and challenges, one can still have a positive developmental trajectory and grow and thrive. It's about overcoming the odds, sustained competence under stress, as well as recovery from trauma. And one of the things with resilience, so I think we do a better job of measuring and understanding risk and trying to target risk. There is a lot of information about resilience, but we need to further understand it, especially as it relates to how do we build out resilience in children, and I'll say as well as with parents. Okay, so as a protective factor, then we know that parental resilience is a protective factor. It's their ability to cope with everyday stressors as well as that occasional crisis. They're able to ask for help, which is really a strength. It's an important strength. Other examples can be faith. For some, their faith is a really important component of resilience, flexibility, communication skills, and then mutually supportive, caring relationships is another piece of that. So that social support, positive social support, having a positive social network is really important. There are threats to parental resilience associated with coping skills, a parent's own history of child abuse and neglect, their physical or mental health problems, if there's marital conflict, domestic violence within a parental relationship. Okay. As well as exposure to community violence. I will say, when I was a practitioner and we were serving 110 children in our therapeutic childcare center, and this was in a different state, but at the Children's Place in Aiken, South Carolina, actually, there was an incident that there was exposure to violence that everyone in our community knew about, that one of our families had experienced. And we did an informal survey of those 110 families, and over 90% of them had witnessed some kind of violence, whether it was interfamilial violence within the home or community violence. And so when kids are exposed, parents are also living with it as well. And so how do we support parents with this exposure as well? So again, coming back to that, so they can be a buffer. Working with families of young children is empowering parents, partnering with parents so that they are able to be that resource that their kids need, that they can help their kids reach their full developmental potential, which often means parents then need that support to help them overcome challenges that they may be facing as well. Oops. And then I really like Marsha Walsh's concept of family resilience. So moving it from the child or the parent all the way to the family, in this idea that, they're struggling well with the challenges. They may not bounce right back, but they're working through it. They're struggling through it. And this is tied to strong, positive social networks. It's the ability of the family as a functional system to withstand and rebound from adversity. How do we shift from seeing distressed families as damaged to understanding and responding to the challenges that they're experiencing? So we talked about ACEs. I really like Grudo and Morris's concept of, as an antidote to ACEs, we actually have PACEs, which are protective and compensatory experiences around that unconditional love, that positive regard. So thinking from social work, that unconditional positive regard, having friends, having a social network, volunteering, being a part of a group, living in a home that is clean and safe and with enough quality education. Hobbies are protective experiences. Being physically active, also having rules and routines within the home. So as we think about intervening with families of young children, how are we building these facets as well? How are we building out PACEs? Of course, we want to prevent the ACEs, but we
The internet and Zoom today is not our friend. I'm sure Trish will be back on momentarily. I want to draw folks to your attention to the chat. Oh, there you are. Great.
I'm so sorry.
It's okay. I know sometimes we don't know when we're getting cut off by Zoom. I think you were just finishing up that last slide. So
okay.
Yeah,
so
no, I think you had gone through rules and routines.
Okay, rules and routines. And so the importance is, how do we, in our interventions, not just focusing on reducing risk factors, but building out the protective factors, supporting families to from a very strength-based perspective on recognizing these protective factors and helping build those out within families. And I will also say within communities. All right, and then timing. And so timing matters. But more often than not, the developing child remains vulnerable to risks and open to protective factors throughout the early years of life and into adulthood. And it's the open to protective factors that is most, that I want to highlight. Of course, they're vulnerable to risk, but they're also open to those protective influences much longer than just in early childhood, which I think is important framing. If a young child really has a lot of adversity early on, without that buffering adult, without that supportive environment, we shouldn't give up on them. We can still make a difference in their childhood and early adulthood as well. So as we think about emotional and behavioral health, social emotional development is at the heart of that. And that does happen within the context of relationships. And so I love the concept of serve and return. And that's just like for anybody who plays tennis or ping pong or actually pickleball, it's, you serve, they return, you return. It's that reciprocal nature of interactions. And these serve and return interactions do in fact impact they shape a child's brain architecture. So when you have an infant that babbles and is gesturing or is or cries, and an adult responds with a gaze, with eye contact, with a hug, there are in fact neural connections that are made that positively impact the brain's development. And so it is that back and forth. And so we want caregivers who are really sensitive and responsive to the young child's signals and needs. And then through their responsivity, then they're engaging in this serve and return that is building out those neural networks. I like how Applegate and Shapiro talk about those caregiver interactions, that dynamic affective interactions between normally developing infants and attuned caregivers. So those responsive caregivers take the form of an intricately choreographed dance in which each partner follows the lead of the other in order to achieve a synchrony designed to minimize negative effects and maximize the positive ones, which moves into child synchrony, which is that dynamic process by which hormonal, physiological, and behavioral cues are exchanged between the parent and the child. And Ruth Feldman and her colleagues have actually demonstrated this actually begins during pregnancy. This begins in utero. And this biobehavioral synchrony is really the foundation for the parent-child bonding, for parent-child bonding, that relationship, that attachment. These patterns are characterized by social responding, mutual responsivity, and co-regulation. And I will say, Susan Perlman, who is at the med school, and a team of others at the med school, have in one of their clinical labs do a lot of work around parent-child synchrony. And this is both, so behavioral is measured through observations of the parent-child interaction, and there's also neural synchrony, which is measured using EEGs and hyperscanning technology, where we actually can see changes in the brain, changes in the brain, changes in what's lighting up in the brain in both the parent and the child. I want to say that much of this work was initially done with mothers and the mother-child interaction. There has been more work now that has looked at the father-child interaction. as well as and so mother child and father child synchrony in couples, but also in the dynamics in LGBTQ families. And we see within fathers in same-sex marriages that the same patterns. You see the same impact on the frontal cortex in the father as you do within mother. So there's some really cool work that's being done here as well. And it does have an impact. So this parent-child synchrony has an impact on the development of self-regulation, symbol use, and the development of empathy across childhood and adolescence. And is in fact, though, adversity can reduce this synchrony. So Feldman and colleagues have found that it's sensitive to some developmental risk, including prematurity, as well as maternal depression and anxiety. Susan Perlman and her colleagues have found family income. So those families with economically disadvantaged families, as well as families where there's a lot of household chaos, that those risks are associated with both just decreased behavioral and neuro synchrony. And if we think back to that household chaos, that's also been identified as a contributor to toxic stress as well. And I want to be cognizant of time here. Going to move through disorders in early childhood into culturally appropriate responses and then into interventions. And so I was going to build out a lot of statistics on numbers in each disorder, but the reality is that a surprising number of kids have young kids, very young kids have mental health conditions such as PTSD, as well as depression and anxiety. When we look at a sample that is kids living in poverty, it's nearly a quarter. So that is a substantial number of young children that are experiencing early emotional and behavioral health conditions. And so I want to talk about real quick living in poverty. When we look at the disproportionality of marginalized populations, Black children, American Indian children, Latino children, living in poverty as compared to 16% of all children, but a much larger percent of Black, American Indian, and Latino children living in poverty. It's really essential that we're thinking about culture and culturally responsive interventions as we engage with families. I'm going to skip my slide on culture and the definitions of culture, and move to, I am going to touch on this one, using a perspective of cultural humility, recognizing that this is a long learning process. It involves compassionate self-reflection, which is more than self-awareness, which is under sort of the cultural competence framework. It's being open and teachable, identifying, acknowledging, and working to redress power imbalances. And it's around partnering with clients. In much of my research today, we talk about our parent partners versus our clients. But so it's that attempting to redress some of those power imbalances, and we're partnering with parents. They are the experts on their children, and honoring that, trusting that, and building from that. The other piece I want to just highlight with cultural humility is the acknowledgement that we can't know what we don't know. And that is so true and so important. As culture relates to child development, it impacts every aspect of human development. It reflects child rearing beliefs and practices designed to promote health adaptation. So it's not, there is not a one right approach to parenting and to child rearing. There are cultural differences that have to be honored, valued, respected, and not come in and say, this is the only way, that is based on a white middle class research done with mostly white middle class families. So that's really, really important. And as I then shift to evidence-based or shift to interventions, this idea of evidence-based interventions that one intervention can't meet the needs of everyone. And so who has the research been done with? Is it culturally responsive? Does it work with African-American parents, with American Indian parents? Is it honoring and respecting their cultural practices, their cultural beliefs? So I acknowledge that it is really a challenge as we think about this. So intervention around infant mental health, which I have touched on some along the way, is about promotion. So we have there is this idea that we want to promote positive mental health. We want to help children reach their full developmental potential, their social emotional competence, and so we do that through interventions that are around promotion of child and family well-being. There are also prevention. So we're preventing, we're intervening to prevent adverse experiences. And then there's treatment. Once an adverse experience has happened, trying to intervene to in fact have fewer adverse outcomes, or to get better outcomes, get better long-term outcomes. And then maintenance after the treatment, working to how do we maintain those what was achieved in treatment. And I will say, across some of the classifications of intervention, that the interventions are the same. So sometimes they're used to treat, and sometimes they're used to prevent. Now, some are very specific, but some can be both, and we'll talk some about that. And can you hear? My internet connection is unstable again.
It was a little bit wobbly, but I can hear you for the most part.
So sorry. So we want to intervene early to prevent more long-term problems. Let's just say that. A promotion intervention, thinking about promotion, thinking about increasing risk factors, or increasing protective factors, reducing risk factors. There is a community engaged intervention called parent cafes that is about building out parent leaders. Parents take a take leadership roles as table leaders, sharing information with their peers within this model. It's about fostering meaningful relationships. So we think about those, social connections as a protective factor, communication as a protection factor. It's about building those out. And it does align with the protective factors that we discussed above or previously. And Vitality Cafes use this same peer-to-peer learning model, but it's around holistic wellness. So domains are financial, mental and emotional, health of the parent. This is focusing on the parent, their physical health, their social connections, as well as their spiritual health. And so this cafe model is a really promising model around promotion of well-being. It's often talked about a prevention, and I believe it is. I love the model. I believe that it is also a prevention model. We don't have as much evidence in terms of prevention, but we're getting there. We're getting there with it. But it is a really promising model. A model that is often used then to either prevent or treat behavior problems is parent management training, which looks at changing parents' behaviors to affect change for young children. And actually there are models that go all the way down to 2 with this. I'm sorry, I didn't change that slide. I'm going to skip over the antecedents, but it is so by changing how parents respond to their children, increasing their parenting, reducing their parenting stress, that we ultimately get improved child behavior outcomes. I want to leave time for questions, so I'm going to skip over. It impacts both, they target both discipline as well as that emotional relationship. I'm going to skip over these. I'll share with the slides with Sarah, send them out if you'd like. There are multiple evidence-based models. And then when we think about it, I want to touch on child-parent psychotherapy really quick as a treatment model for that. I talked a lot about the parent and the child's exposure to trauma. And this is then a didactic intervention when both the parent and the child have been exposed to that trauma. And it's based on really this idea of ghosts in the nursery, which is the intergenerational transmission of negative relationship patterns during those first years of life. There is a counter, and that was done by Ghosts in the Nursery, was put forth by Freiberg, and Alicia Lieberman has some papers around angels in the nursery as well. I want to just put that out. There are also positive parenting experiences that shape how a parent interacts with their child as well. And excuse me. It's about helping families. It's supporting family strengths and relationships. It is strength-based. It's for young families of young kids. It helps families grow and heal after stressful experiences. It does respect the family and values. And it is based on the understanding that parents and caregivers know their children and are central to their development, that idea that parents are the expert, and that stressful experiences affect the parent-child relationships, and young kids do rely on their parent to feel safe. And there is strong evidence supporting its effectiveness. I'm just going to put a plug in. We all need to be following Baby's First Year study, because it's looking at the impact of an economic intervention on on child development with some really great early outcomes. And I'm going to stop there and stop sharing my slides, and I'll take questions. I talked longer than I was supposed to,
Yeah.
and I'm sorry about the challenges with the internet.
It is okay. It happens. And we will, you said we can share your slides, so we can share Dr. Kohl's slides as a PDF. I'll put a link in the, I've been putting a lot of links in the chat. I'll put another link in the chat to where you can view not only her PowerPoint slides, but also the recorded session if you want to rewatch. So we've had a few, like several questions that I'm going to try to get to a couple of these. All right, here. So we talked a lot about what parents can do, especially like moms with the baby in utero. But I did have a question from a parent or from a grandparent who is here. And she said that her grandchild was born premature and is now having, is not maybe being cared for in the best way. And so she wants to know, as like a peripheral caregiver, some concrete good interventions, or even just some small things that she can do to provide some buffering, even if she's not the direct parent or direct caregiver.
That is a great question. And I will say we talk about that buffering caregiver often as the parent, but it can be anyone. So it is a consistent present in the young child's life that is responsive to the child's needs will in fact serve in, can in fact be that buffering relationship. Because we know that sometimes the biological parents just aren't at a place that they can do that, but others can step in and do that, and kids can do still thrive and flourish and do really well.
Yeah.
And so those thinking concrete, it's that back and forth, that reciprocal relationship. I don't know the age of the child, reading to the child, talking with the child, playing with the child and I always talk with my hands in that back and forth manner, can really help them grow and develop.
So in other words, what I hear you saying is you don't have to be implementing a therapy. You don't have to be a therapist implementing a therapy in order to still be therapeutic. You can do those normal interactions. You can do normal play and just respond, picking them up when they cry, smiling at them when they smile at you. That's great.
Absolutely. Absolutely.
So another question, what if you are in a situation where you actually know that there's going to be some trauma coming up? So if there's going to be some medical trauma, we obviously, some of the other traumas that you talked about, those are not things that you ever want to plan for, right? But there are some things where that might be the case. And so if you have an infant or a young child who's going to experience some medical trauma, are there things that you can do leading up to it or during it or right after to help mitigate and buffer the effects of that trauma?
It's being there. It's that, again, it's not, there is a specific intervention as we think about, those manualized interventions. It is being responsive. Nurturing, hugging, making eye contact, touch. Touch is actually really can be really therapeutic. There are, and I didn't talk about it today, but baby massages are incredibly therapeutic, both for the caregiver and for the child. Now, there are sensory issues that can come in. Some kids, young kids and kids with prematurity may be at risk, may have some sensory issues. So the touch that feels good to them may not be that soft touch, but finding out. And OT, as we think about touch, occupational therapy is a great intervention with kids around sensory issues. But I encourage you to look at baby massage.
That's great. And that also makes me think, you talked about cultural differences and respecting that one intervention is not going to work with every cultural group or people of different races, ethnicities, but that brings to mind different disabilities. Kids with different disabilities might have different needs in terms of how they need to be cared for and buffered, right?
Absolutely.
All right. Well, it's the end, and we had a lot of good questions, but I do want to. Oh, yes.
What I was going to say is, let me put my email in the chat real quick. And if anybody, can I do it to everyone?
Yep, you should.
And if we didn't get to a question, and if you have one, please feel free to send. Please feel free to send me an email, and we will email you the slides.
Thank you so much. So Dr. Kohl's email is in there. I also just put a link to where you can find the recording on YouTube, as well as the slides that we will post.
Okay.
And then our next open classroom program is on February 28th. It's called Fighting for Flourishing, from girls boxing to community operatives. And then actually Dr. Kohl is leading another open classroom that's March 28th. And that's again, looking at supporting families and supporting child safety and well-being. I also put in the chat a couple of other workshops that we have around culturally responsive interventions with different groups. And so if you're interested in those, please take a look at the links.
And I will say, the event on March 28th, I am moderating a panel.
Oh, yes. I'm sorry. I forgot to mention that. Yeah, moderating. But that'll be great, hearing some other voices on this topic. So we are 1 minute over time. So thank you, Dr. Kohl, for your presentation today. And thank you, all of our attendees, for your excellent engagement and questions. Bye-bye, everybody.
Bye-bye.